Welcome to everybody. Thanks for coming to this poster session focused on substance use. I am Tina Stutz. I'm an associate professor and an implementation scientist at COPRH at the University of Colorado. And my co-moderator is Claudia. Go ahead, Claudia.
Yeah, I'm Claudia Murad, from the College of Nursing, and also heavily involved in implementation science more and in substance use. So also this is kind of my topic. So welcome everybody. So I'm going to introduce the first speaker is Jesse Hind. I hope that I pronounce it correctly, talking about from RTI International, talking about economic evaluation in hybrid type 2 trials, evidence and lessons learned from the substance abuse treatment to HIV care project. Go ahead, Jesse.
Thank you, Claudia. Let's get my timer going, keep on track. So again, I'm Jesse Hind. I'm a health economist at RTI International, and today I'm going to share some work that we've been doing for an economic evaluation of a hybrid type 2 trial. So just as some context, substance use among people with AIDS is both prevalent and problematic, yet AIDS services organizations do not commonly integrate substance use treatment. Brief interventions may reduce unhealthy substance use and are good candidate service for AIDS services organizations. However, implementing BIs has often proved challenging. So in this study, we examined whether a team-focused strategy like ISF improved the implementation of BIs relative to an existing gold standard staff-focused strategy used by the Addiction Technology Transfer Centers, or ATTCs. In the main findings study, we found that the ISF resulted in staff delivering more BIs and higher quality BIs, as well as reduced substance use among clients receiving a BI. Given the effectiveness of ISF, the next step was to understand what it cost and whether it was cost effective. So in our protocol, 19 clinics randomly received only the ATTC strategy, and 20 clinics received the ATTC and ISF strategies. We used a payer perspective to estimate the cost per staff in each study condition. We collected information on the quantity and prices of resources used for activities in each strategy, plus time spent delivering the BI. The ATTC activities included a 5-hour web training, a 2-day in-person workshop, feedback reports, and monthly coaching calls. And each clinic had 2 staff trained using the ATTC strategy. The ISF activities included 30 to 60-minute facilitation calls every month with clinic staff, as well as 1 4-hour in-person facilitation meeting. Using multi-level generalized linear models, we predicted adjusted differences in costs and outcomes across the study conditions, and then calculated incremental cost effectiveness ratios, or ICERs, by dividing the difference in the cost by the difference in the outcomes. And then we used a threshold of $50 to determine whether it was cost effective. We estimated that overall in Exhibit 1 there, that the ATT strategy cost about $3,300 per staff, and the ATTC plus ISF strategy cost about $6,000 per staff, which yielded an incremental cost of about $2,700. We assessed 2 implementation outcomes, the number of BIs delivered, and then BI quality. For the quality score, each BI session was rated on 10 different components, using a 7-point scale for adherence and competence. As you can see in the results, ISF increased the number of BIs delivered by 4 and increased the average quality score by 61 points. As you look in the next column, the ICER for the number of BIs delivered is $719, which means that ATTC plus ISF is cost effective if we are willing to pay $719 for an additional BI. Clearly that falls way above our $50 threshold, but for the quality outcome, it does fall under with an ICER of $44. That brings us to the first challenge that we highlight is sort of the scaling issue that we had. Staff were asked to deliver 3 BIs per month, but many staff treated that as a quota. So to get under the $50 threshold, staff would have needed to deliver 9 BIs a month. Although the per month goal was implemented to focus on quality over quantity for the effectiveness trial, such low recruitment rates will usually lead to a determination of not cost effective, given the relatively large cost inputs that went into training and supporting the staff. So in planning a hybrid trial and implementation trial, researchers should consider what the plausible range of incremental differences in costs and outcomes would be, and whether that range might lead to a cost-effective result. Now, we don't often know what those costs and outcomes are in advance, and so thinking about some hypothetical examples or some basic simulations, that may be a tool that could help us inform decisions around the study protocols. Turning to our other outcome, which was client days abstinence, we also found some challenges here in how we define that outcome in the model. A priori, we thought using a staff level outcome that summed the days abstinent follow-up across all of staff's clients best captured the total impact of the strategy. In this field, we often use client level analyses and incorporate baseline measures of substance use into the model. So we attempted some sensitivity analysis to replicate that. As one model, we included the average of clients' baseline days abstinent as a covariate. And in the last model there in the last row, for each client, we took the difference in baseline and follow-up days abstinent and summed up the differences. As you can see, only our first and preferred outcome was cost effective, but you can also see that the outcome definition strongly influences the interpretation of our findings. So what we want to highlight is that future trials should consider sort of these modeling issues as they approach their economic evaluation, and also like the first challenge, the scaling issue. So for the bottom line, we find some evidence that ATTC plus ISF was cost effective for improving implementation outcomes and reducing client substance use in the trial itself, and feel confident that if this was scaled up into a larger setting in a real-world rollout, it would be cost effective. In closing, I want to acknowledge our funding support from NIDA and the contributions of my fantastic RTI co-authors here. Thank you.
Perfect. Thank you so much, Kelly, for your, Jesse, for your presentation. And I have one question on to address this addiction technology transfer that you have. I'm working on opioids and also on HIV, and we see these clusters that are happening more and more with because of heroin use of HIV prevalence or more incidence. So how are you with this model? Do you put them in one payer system or the other, or how do you categorize to integrate your cost-effective model for payment? Oh, I cannot hear you.
Sorry, I'm on mute. So the ATTCs are largely grant funded, and SAMHSA funds a lot of the ATTCs to provide these services to their grantees and other organizations. So we approach the evaluation from sort of that perspective of what would SAMHSA want to pay and sort of what would they potentially get out of this. So we didn't necessarily take into account the different payers. These specific aid service organizations were largely HRSA funded for the actual services they provide. And so I think as we build on this, the next step is to think about, sort of other services that we would want to bring in and sort of how we could potentially leverage the ATTCs and using the ISF to support other things like medication assisted treatment.
Okay, great. Tina, do you have, I don't know if you have, I think that we are
Well,
on
I
time.
always have a question, but I wanted to see if anybody else has any questions.
Jesse, I have a quick question. This is Brian Hartzler. I think we've met. The $50 reimbursement rate, would you say that that is context specific to HIV care settings or a broader reimbursement rate from a range of settings where BIs occur?
Yes, thank you, Brian. It's good to hear from you again, too. So the $50 was taken as an average of the mix of the reimbursement codes that SAMHSA has on their website for brief interventions as a whole. So it's not specific to the aid services organizations, it's more broad, but it is specific to brief interventions. So, one thing that we were thinking through is what the right threshold should be, because there's not necessarily clear guidance on what we should use. So this is what we think was a sort of a good guide since we took, again, that perspective of SAMHSA.
Thank you.
I have one quick question. We have just a little over a minute left, probably, Jesse. But my question, so, cost and cost effectiveness is incredibly important in all of our kind of implementation and pragmatic research. And then people often lack expertise in this area and need to find people with expertise, you know, in that kind of evaluation. And the data collection piece always seems to be challenging. So like there's this balance between wanting an easy way to collect cost data and then like an accurate way to collect cost data. So I'm curious how you all collected in this study and any recommendations you have for people who are interested in getting into this area in their own work.
Yeah, so thanks, Tina. And I think there's a few others on the call that I see who might be able to chime in on this as well if we have time. But I think as perspective as you can be in the process about and thinking about how you're going to collect the data. For this, some of my co-authors on the team who really worked on implementing the study, I'll admit I kind of came in on the back end and helped figure out the economic evaluation part, but they did a fantastic job documenting everything. So for all of the different activities, we had some primary data, at least on how long it was, who came, some general information about their credentials and things like that we could use to piece together different elements that we need for a cost study. So, price times quantity, we need some measure of what the different prices are. So we had done a staff survey that collected information on wages of the different staff that were involved at the clinics. And then for the quantities, we had they had a bunch of different basically project trackers that were able to track some of this information on a rolling basis. So we were able to do this, somewhat prospectively with a little bit of, waving of the hands at the end as we try to fill in a few gaps. But I think in working with Brian and some others on this call, we're just trying to be a little bit more thoughtful as we go into the study about like, what are we collecting the right things that might support an economic evaluation if we decide that that's what we want to do.
Fantastic. Thank you so much. So I of course would follow up with you about this, but maybe I'll just email you and I want to make sure we preserve time for all of our presenters. So thank you so much, Jesse.
Perfect. Thanks, Jesse and Tina. We are going to move on to Kelly Scott from Brown University presenting a protocol for a pragmatic pilot trial implemented measurement-based care in community opioid treatment programs. Go ahead, Kelly.
Great, thank you. So as you mentioned, I'm Kelly Scott. I'm an assistant professor within the Brown University School of Public Health and also an implementation scientist. And I'm very excited to be presenting on this very recently funded K23 award focused on implementing measurement-based care in community opioid treatment programs. And so for some background, as I'm sure those of you on the call are aware, the opioid overdose epidemic continues to be a major public health concern in the United States. And this is especially the case in the New England region, where we have several states that are very much in terms of high prevalence of opioid overdose deaths in the United States. And currently our opioid treatment programs offer medication for opioid use disorder, which is considered the gold standard treatment. But a lot of times there are barriers in terms of treatment engagement, as well as suboptimal long-term outcomes. And so increasingly the research field, as well as clinical practitioners, have recommended the pairing of adjunct psychosocial interventions alongside medication. And measurement-based care, which I'll be talking about today, is one evidence-based practice that may be uniquely well-suited for use in opioid treatment programs alongside medication. And the reason for that is because it's a relatively easy to use, quick process by which folks can track treatment progress. So measurement-based care, for those of you who are unfamiliar, involves a systematic assessment of client treatment progress, typically with a self-report tool that the provider then reviews and uses to inform the treatment plan. And so measurement-based care might be really useful in opioid treatment programs where there's frequent dosing requirements, there's a lot of patients coming in day to day, and they're really relying on group-based psychosocial intervention models. So you can have measurement-based care in those systems. So this project has 3 specific aims. The first of which is using a very novel method called Rapid Assessment Procedure Informed Clinical Ethnography, which was developed by Lawrence Palinkas and colleagues, one of the mentors on this study. And the goal of this method is to collect really systematic mixed methods data that lets you really understand the context of the agencies and programs you're exploring. And so we'll use RAPIS to build community partnerships with 8 opioid treatment programs, and then also use it to collect some really systematic qualitative and quantitative data that will inform both the adaptation of a measurement-based care protocol specifically for opioid programs, and then also inform some site selection for AIM-3, which is a pilot measurement-based care implementation trial in this setting. And so I'll draw your attention to the center panel, which highlights measurement-based care's core steps. So typically measurement-based care involves patient measure completion, and that will be the self-report measure typically, followed by a provider measure review in the session, and then a formal discussion in session. In this case, it might be in a group therapy session. And then the last core step is documentation in an electronic medical record. And so that's where we might do some adaptation work using RAPIS, which is our phase 1 down below, starting with some really formalized clinic site visits that our team will do. And coupled with that, we'll do some cognitive interviews where we'll actually get to know what types of measure, content, questions, specific topics that both providers and patients in this setting would like to see and would help them optimally guide their treatment progress assessment. We'll also be doing some quantitative surveys guided by the Consolidated Framework for Implementation Research. So we'll have an opportunity to learn about the context before moving on with the adaptation. Then in stage 2 of RAPIS, we'll do a concurrent qualitative and quantitative mixed methods data analysis that will be rapid in nature. So we can quickly move to stage 3, which involves selection of 4 sites for our measurement-based care implementation approach, as well as finalizing the measurement-based care protocol and doing the adaptation work. And all of that will lead to phase 2, which, as I mentioned, is the implementation study. And so that will involve measurement-based care integration into the electronic health record at each site, and then measurement-based care workshop training that will be provided to treatment providers at each of the 4 sites, along with ongoing support. And the form and function of this ongoing support is going to vary based on the RAPIS findings. So we're really curious to know what kind of support might providers most want in terms of what will be covered, the structure, the frequency. And so that will really be guided by the data from the ground up. And then of course, we'll be doing outcome assessment and with a keen eye towards both effectiveness and implementation outcomes. And so for primary effectiveness outcomes, we'll look at patient attendance in treatment, as well as opioid abstinence. And that'll be done prior to and following the measurement-based care implementation effort. And then for implementation outcomes, we'll look at provider measurement-based care exposure, as well as fidelity to the core components I listed up above on the poster. And so really the goal of this project is to improve the assessment of treatment progress for individuals in care for opioid use disorder, and also to study and enhance the use of measurement-based care and evidence-based psychosocial interventions in general as adjuncts to medication for opioid use disorder. So that's my very quick overview of a 5-year study. And I'll go ahead and stop there and welcome questions.
Great. Thank you, Kelly. That was a very nice presentation. So I have a question, and Tina and I probably gravitate towards the same of the adaptation that you are going to have on this program, because you are trying to use RAPIS to do the study design, but you are testing in a few sites. And then how do you envision them being different or being similar, and what are the components, and how are you going to make the decision on what are the components that need to stay, that they are core components, and what are more contextual that needs to be changed or adapted depending to the site or the context or the individual needs?
That is a very good question.
And probably I stole Tina's question.
We share a brain, Claudia. So my question was
that works. You can combine it together. So I think the core elements are the ones listed there. So when measurement-based care is delivered, I think it's really important for it to be delivered with fidelity, because the theory says that that discussion component is really vital. Just doing a measure is not necessarily going to move the needle on outcomes, but the discussion may, and the change in treatment. And so that, I would say, is core, and the adaptable periphery, so to speak, may be how it's delivered in individual versus group counseling, the frequency. When I've done this type of work before, sometimes sites prefer, weekly, monthly. Sometimes they, do it every single time a client comes in for a session. Sometimes they don't. And so I think there's potential there for adaptations in terms of frequency. And, the hope would be that this would be a measure that could be consistent. But there might be some other areas in terms of content and specific subject matter in the measures themselves that might be adapted as well.
Perfect. Thank you. Other questions?
Great work, Kelly. I'd like to piggyback on what you were just saying about the measures themselves. And do you have some preliminary thoughts as to what type of measures or data you think will be most valuable for these opioid treatment programs?
Sure. So, and I have to thank Sarah. She is my primary mentor. So she's kindly asking some questions here. So one of the recommendations in the literature as a starting point is to start with the DSM-5 criteria for opioid use disorder and kind of have an ongoing monitoring of severity of symptoms guided by the DSM-5. But one of the questions I had is that sufficient? And will it be practical for use by clinicians who are practicing day-to-day, seeing their clients monthly? And are there other things that they might be interested in? And that could be, other potential psychosocial stressors someone might experience, other symptoms that commonly come up, potentially comorbid disorders that they might like to assess. And also, is the wording of the questions from the DSM criteria sufficient, or does it need to be altered, for comprehension purposes, for clinical utility? And so I think there's both content-related questions that might be adapted, but also wording specific questions and how the questions are asked as well.
Excellent. I don't know if others are just seeing a black screen, but I only see a black screen where it says someone start. Is that just me?
Yeah, we
Okay.
see a poster.
I have a quick, this is a 30-second question, or maybe less, Kelly.
I'll do my best.
This is another RAPIS question. Is there an adaptation process built in to RAPIS, or are you using sort of an adaptation process and adding it on? Like, just to get a better idea of, I look at the 3 stages and there's this adaptation step in the 3rd stage. Is that a guided, like when you describe RAPIS, for example, to grant reviewers, is there a process that adaptation follows, or does it just say adaptations are going to be made based on, what we learned in the first 2 stages?
Okay. I think in the original grant, it was more the latter that you mentioned, but the goal would be that the RAPIS process would identify the adaptation targets, and that it would be an adaptation process happening with the community partners throughout the process. So even within stage 2, where we're doing the concurrent data analysis, we would have the opportunity to go back to the leaders and providers at each program and get some feedback. We're hearing that monthly sounds like the optimal measurement-based care dose. Does that fit? And really then guiding that adaptation through. So it's a little different from using a more formalized adaptation framework, but the RAPIS is very nice for identifying those targets, but having it be iterative and interactive with the partners as well.
Wonderful. Thank you. I was very curious about that. So that's a great answer. Okay, well, thank you. We're right at the end of the 10 minutes. And so thank you so much, Kelly, for your presentation and sharing your K23 protocol with us. And congratulations on getting that funded. Very exciting. And I can't wait to see what you do with this in the future. So for our last poster, I will quickly introduce Claudia, who's already been moderating in the session. So Claudia is going to be presenting her poster, Planning for Sustainability of Medication for Opioid Use Disorders Services in Rural Colorado.
Perfect. Thank you, Tina. So I had a great introduction from the previous two speakers, but opioid use disorders, as we know, is a national epidemic. COVID has had a big impact, but it is still a main problem in the US. Colorado ranks 12th nationally, and particularly with rural areas having the highest opioid-related deaths. And as discussed, the medication-assisted treatment for opioid use disorder, or MOUD, is an evidence-based practice that is very effective, but despite this, is not highly utilized, particularly in rural areas. So based on a success of a program that we implemented a couple of years ago in piloted in 3 sites, the medication-assisted treatment, or MAT, then MOUD expansion, funded 9 healthcare organizations to bring both MOUD, which includes with pain management, medication, and behavioral therapies throughout Colorado. So these posters presents the evaluation of this expansion efforts, the challenges and lessons learned, and some sustainability of the program. So we collected organization and de-identified patient level data monthly, and use PRISM and REAIM framework to inform the context, the reach, the adoption and implementation, and some plan of maintenance. And we use a SWOT analysis to understand challenges, barriers, and inform sustainability plans. So the program, as you see in the map, has 9 healthcare organizations to provide the treatment, and the service provision in rural areas is very challenging due to geographical barriers, particularly in Colorado, that you have mountain ranges and is very fragmented. So our model, or our program, used a model called hub and spoke model, which connected, as you see in the map, central hubs or primary facilities that were trained and coordinated by the University of Colorado College of Nursing. And then the spokes are the satellite clinics for a continuity or network of referral and treatment, which is ideal for reaching underserved rural areas. And so it has this anchor and satellite side. And you could see the complexity of the system and the growth that it had over time. So in the last 18 months, we expanded from 3 sites to 21 counties, rural and frontier counties, with over 43. This up to yesterday kept expanding, 43 clinical sites covering a very vast geographical area. So as you could see on the top, this program serves a very diverse population with patients that have previous issues with substance use. They have polysubstance use. They also have a high rate of unemployment, much larger than in the rest of the state, with legal concerns and problems to healthcare access. So as we started growing, COVID-19 hit, and that impacted services providers and patients. So the most significant and drastic were it impacted services and providers and the service for patients. Despite that, the system grew to over 1,000 patients, as you could see in the map in the graph, despite growth. And then the comprehensive SWOT analysis show a lot of strength that was mostly given this expansion and the patient-centered services and this growth of partnerships, but also show a lot of weaknesses that also demonstrate the need for continuing supporting the sites, and particularly utilization of these care coordination systems to support this expansion, and use of peer coordinators to help with patient navigation. I think that I was over time, so I apologize for that. I think that I'm on time now.
That was excellent. We have just a few minutes left for Q&A. Thank you, Claudia, because I know you have a lot of information to present, and you can probably answer any question that anybody has to ask about. I will say your SWOT analysis was focused on sustainability, right? Like thinking of how this could. So one thing I'm just going to comment that I really appreciated is that you have the advocacy point in your future directions, because this was like a state initiative, being able to present them with the data that the services actually were expanded, and during this like crazy COVID time, the growth is like really impressive across the counties. How are you presenting data to them? Like when I think about sustainment for this project, what is going back to the decision makers who are going to decide whether to expand, restrict, and continue the funding for this project?
Yes, thank you, Tina. And actually, we are doing town hall meetings with each community, in each community, which the grantee and their community, to present individually their data, because we have a big barrier still of stigma to overcome in the community, and particularly with the switch to telehealth, that was not easy. And that is for the communities to sustain those non-traditional partnerships that may not be clinical, but it may be connection with school system, connection to the legal system for referrals. That's one. And the other is with the legislature. So I put together a brief that we presented a couple of months ago, and we are with the legislature in session right now. We are putting together, well, I'm putting together with the whole team a report for the legislature due in just 2 weeks. So it's in the, I'm writing that with all this data. Is much lengthier, but it's a report for the legislature advocating for further funding, because there is still a big need. And particularly, you don't see the individual graphs, but at the very beginning, there was a very big time of lag until those partnerships fell in place, particularly with COVID, and then they start soaring. Thanks for the question.
Fantastic. Any other questions for Claudia? Okay, I'm keeping an eye on our time. I think we only have like about a minute left. And so with that minute, I just want to thank everybody for coming to this poster session, for taking the time to share your work with all of us. It's really thought-provoking. I think all of these, around expanding services in rural areas, about integrating behavioral health or psychosocial treatment into MOUD, and then Jesse's like bringing the cost and cost effectiveness analysis into this kind of research. These were all really interesting topics and super relevant to the conference theme, and also what each one of us is doing, even if we're in areas outside of substance use. So thank you so much to all of you. It was really interesting to hear your presentations, and please feel free to follow up with each other outside of this session if people are looking for collaborations or information about things that they learned about today that were new. And that's it. I'm going to let you guys go and enjoy the next, I don't even know, actually, this is terrible. I don't know what the next session is because I wasn't on the page. But enjoy whatever's coming up next.
Thank you so much. It was great to learn about your projects.
Thanks, everyone.
Yes, take care.
Bye.
Thanks,
Have a good day. Bye-bye.